Welcome to Let's Talk Micro.
Hello, everyone. Welcome to a special edition episode of Let's Talk Micro. I hope you're doing well. So, in light of the recent news, we have seen on the TV, we have heard on the radio, seen on social media, posts, information about monkeypox. So, I thought this would be a good time to bring an expert to talk about monkeypox. That way, we can educate yourselves, you, the audience, and myself as well, more information about monkeypox, what kind of virus it is, signs and symptoms, treatment, and information about outbreaks. So, this episode features an interview with Dr. Rodney Rohde. He's a professor and program chair at Texas State University in the Clinical Laboratory Sciences program. He's a microbiologist. He has a lot of experience. He spent some time with the Texas State Health Department. So, this is a very educated and experienced person. He's also a great advocate of clinical laboratory sciences. So, if you're involved in microbe journals, in publishing, or advocating for clinical laboratory sciences, you have heard of Dr. Rodney Rohde. Very nice person. I had a great time interviewing him. And like I said, he has so much experience that I'm going to bring him in future episodes. But in the meantime, I hope you enjoyed this episode about monkeypox. Let's listen to it. So today's episode is a special edition episode. It's outside. I normally do one episode a week, but I was, we're all looking at the TV, and seeing the news, and we have heard about the monkeypox. So I thought it would be a good time to have an expert come in and talk about that. So today I have a guest that's very active in both microbiology and clinical laboratory science. And he's going to introduce himself in a minute. But his name is Dr. Rodney Rohde from Texas State University. Dr. Rohde, welcome to Let's Talk Micro.
Thanks so much, Luis. It is a pleasure and an honor to join you. I was just mentioning to him earlier that I appreciate every person out there that is helping to amplify the message of the medical laboratory, as well as public health and infectious diseases and all the other things we do in the medical lab. And as Luis mentioned, I am Regents Professor and Chair of the Clinical Laboratory Science Program at Texas State University in San Marcos, Texas. I'm also the Associate Director for the Translational Health Research Center, which is a university level research center that really kind of is a big umbrella term that works with faculty across all of our colleges. So not just in the medical lab, but in other areas that have to do with health. So that's a really interesting role. And I continue to adjunct as a community college professor at Austin Community College in Austin. It's where I really cut my teeth on teaching back in 1995, and I continue to do that overall. I love teaching as well as mentoring. So that's kind of my short story, and perhaps we can talk about a career journey in the future sometime.
Yes, definitely. I think in the future, like when we're talking outside before we started, definitely, and for the audience, yeah, Dr. Rohde has a lot of experience, and if you're involved in clinical laboratory science or microbiology, and you're either looking at journals or social media, you will see his name out there. It's very active. A great, you advocate a lot for medical laboratory sciences, and I thank you for that.
Thank you.
Okay, so let's go ahead and talk about monkeypox. So, can you start with an overview of the virus? What kind of virus is it?
Sure. So, I mean, typically monkeypox, you conjure up these images of, monkeys and things like that. And it's actually kind of misnomer because monkeypox was given its name because the first real detection of it was in a couple of colonies of monkeys that the CDC was working on with respect to research. And that was, quite a while ago. And actually, it was around 1958, if you just want to put a date on it. But really, you could probably talk about this as more of a rodent pox, because in reality, monkeys are not the primary reservoir, and nor do they transmitted as quickly as rodents do in other animals. So really, it's more likely in rats and rodents and even types of squirrels. So just a quick little history lesson about it with respect to that particular naming of it. It is in the same family as smallpox. So it's an orthopox virus, and it's the same area that you see cowpox and camelpox and smallpox. And so that's kind of an interesting piece around it. And the current outbreak that's occurring, if you're seeing this on your news, it's really popped up primarily early on in the United Kingdom, Portugal and Spain and some other European countries. And it's kind of small so far. There's about 68 suspected cases. And that also includes, 8 cases in England and I think 20 in Portugal. And really the reason I was telling Luis before we started, it kind of blew up my day today with talking about it, because the United States had a confirmed case yesterday in Massachusetts, and there's a case in Canada as well. So that's probably what's kind of blown it up in our world. But what's really interesting about this current outbreak is that health officials are kind of perplexed on what's going on, because there might be some other atypical type of spread through the community that's undetected, including maybe some new routes of transmission. And by that, the acquisition of the infections kind of remain unclear. And so they're getting a little more attention than normal. For example, in England, 7 of those 8 cases don't even involve travel to Africa or any other country in the Democratic Congo. And so that's where it's typically found, in those parts of the world, West Africa, Central Africa. And so usually you see it more from animal and travel associated cases, but 7 of those 8 cases have no recent travel to Africa. And so they're wondering if that one case may have been together with the other patients, or some indirect contact with that one patient. That one patient was known to have traveled to Nigeria, as the sources indicate. And so they're just kind of looking at that. So they think there might be some cryptic spread through that imported case. They're also interested in looking at the cases from the standpoint, I mentioned kind of an unclear acquisition. Some of those cases were found in a possible sexual contact, just a subset of the overall outbreak. And so that's kind of what's going on right now, Luis.
So you kind of mentioned it. So it is endemic it's typically from Africa.
That's right. And typically the way you catch it is it's typically an animal bite, or you can get a scratch or contact with like the animal's body fluid. So that's one of the primary ways you get it. There is possibility for human to human kind of transmission. Typically that's through inhalation of respiratory droplets from coughing or sneezing. You can also get it human to human if you have direct contact with lesions. So let me back up a little bit, because this particular virus will mimic smallpox. And for those of you out there who are younger, you might have seen images of smallpox patients from way back in the 40s, 50s, and 60s, before smallpox vaccine eradicated it in 1980. But you would get these really large pustules on your exterior surface of your skin, and they're full of fluid. So they're lesions and kind of pustules. And when those burst, there's fluid that have virus in it. And so if that happens between 2 human beings, even if you don't know, like you have a small scratch or something like that, you could pick it up in that route. There's also kind of a lesser possibility for indirect human transmission. If, for example, you had a human being that was sick, had pustules, and they were oozing or opening up, and clothing or bed linen or things like that were shared, or someone else came into contact with that way. So human to human transmission is not super common, In fact, if you look at the literature, there's very few outbreaks that are sustained. They typically die out. In epidemiology, we call that kind of a dead end process. They burn out really quickly. And so it's nothing right now that we're, for example, concerned about, like COVID, where you have massive aerosolization and transmission in that route. But there is some risk when you have that. And interestingly, Luis, what's interesting about this, as I mentioned, it's a cousin of smallpox. So back when there was massive smallpox vaccine going out to eradicate it, people were also picking up some cross-protective immunity through smallpox vaccine. So you didn't really see a lot of it. And when that eradication campaign ended in 1980, there was more cases of monkeypox that started popping up, especially again in Africa, Central and West Africa, because what was going on is now you had people that were no longer as fully immunized as they had been during smallpox. So some of that occurred after those vaccine campaigns went away. So kind of interesting that smallpox actually helped us in our cross-protective immunity, and now that's waning. For example, I got a smallpox. I was born in 1967, and it's about when they were phasing out some of the smallpox vaccines in the United States anyway. And so many younger people do not have that vaccination. And so there is more susceptibility to it in the population, more naive individuals out there because that vaccine is not used anymore.
So yes, it's good that you talk about just so right now it's just a small number of cases, and because of course the public sometimes especially with the lack of information, maybe they hear the word virus again, and with COVID and everything, we're pretty tired of hearing the word virus. So
absolutely. I was telling, as I think I mentioned to Luis before we started, I was telling my wife this morning that it was, this is never a good thing when you have another infection kind of sprouting up and an outbreak occurring, but it was kind of a relief to be talking about something other than COVID, which I've been doing kind of nonstop for the past 2.5 years. So yeah, it's not a good thing, but certainly it's a different topic. It lets us re-examine why it's important to have public health surveillance and why vaccination is so critically important, and getting into infection and prevention and other reasons that surveillance and infectious disease monitoring are so critical to society, even though many people are tired of hearing about it. These things are not going to go away just because we're tired of it. And I often tell people, even though we think, we may be over the pandemic, the current pandemic, many people are tired of it and they're just over it, but that virus is not finished with us yet. So regardless of what people think, it's a sustainable kind of need that we keep cognizant and on top of our public health surveillance, treatment, therapies, and other things. We need to be ready for any, upcoming outbreaks.
Definitely. So you mentioned about the pustule. So any other signs and symptoms, if the person is infected with it?
Yeah, great question. So signs and symptoms, that's a kind of a good spot to hit. So this particular virus, unfortunately, that rash, that pustule does end up happening, a week or so into the infection. But early on, it's really very much flu-like. And so it mimics those typical types of symptoms. So there's fatigue, there's fever, there's coughing and sneezing and other flu-like symptoms. The rash is a little different. And once it gets going, certainly then that is an indication that something else is happening. And so that's a good point, as well as worth mentioning that, just so the audience kind of understands, this is not something that has a high mortality rate. It's actually pretty low. There's two primary clades or viral strains. One is a little more problematic. It has a fatality rate close to 10%. So that's somewhat worrisome. But the other clade, the other major variant is actually down around 1%. The current outbreak is thought to be the more milder strain. And so that's kind of a good thing right now. And so that is important, as well as the transmission rate. Historically, if you look at this, it's kind of around 0 to 3%, a little above 0 to 3%. So it's not something that has a high reproduction number that you might remember talking about during COVID. It's not, some of the highest reproductive numbers. That means one person, how many people can they infect? Some of the highest agents are things like measles, which is up to 20, and chicken pox is in like 12 or something like that. This one's really down low. So that's a good thing with respect to how it's going to be transmitted. And historically, we can talk a little bit about, has there ever been other outbreaks in the United States? And there actually has been. In fact, in my home state in 2003, monkeypox hitched a ride with a bunch of animals from Ghana to Illinois. And you can find this in the CDC MMWR reports and other literature reports that it spread in, I think it was 6 states in the Midwest. And there were about 47 people, I believe, if my memory serves correctly, that caught the disease primarily from prairie dogs, because those animals, it spread out of animals from pouched rats and squirrels into prairie dogs and other things from Ghana. And it burned out. No one died. Everyone recovered. And so that was back in 2003. That was the first induction of monkeypox into the U.S. And then more recently, let's see, there was 2 more times this occurred in 2021. One person in Texas and one or two people in Maryland. And those were travel associated. And those also died out pretty quickly. So it's just another virus that, many people, Luis, had not heard about. And only people like us that work in this realm kind of know about it. I've known about it for 30 years because my first career path, as you mentioned, was in public health. And I worked for the Department of Health in Austin and did a couple of stints at CDC. And monkeypox was one of the things we worried about. We were primarily working in zoonotic diseases, so hantavirus and rabies and plague and things like that, even influenza. And so I was there when this popped up in the early 2000s, and we kind of dealt with it. So it's not a new virus. It's probably been around for centuries and probably much longer. And really, just like other things, keep in mind that it's both a situation where it's probably been around a long time, but remember how amazing our diagnostic tools have become in the last 5 to 10 years, maybe 20 years. And so now we pick things up, way more than we ever did before in our history. And so we're seeing things that perhaps have been around all the time, but we're just able to diagnostically pick it up quicker.
So you were actually, when that outbreak was there, so as you said, so you were actually working for the Texas State Health Department.
Yeah, I left there in 2003. So I started my career in public health in 1992 after my master's degree in virology, and spent a decade there, and started out in newborn screens, which really introduced me to the medical lab profession, because I was working beside back then med techs. Now we call them medical lab professionals or medical lab scientists. But quickly, because I loved infectious disease, I jumped to an opportunity pretty quickly in the first year to virus isolation, which looked at all viruses. So I spent the first couple of years doing, which a lot of people don't even do anymore, doing cell culture and CPE, monoclonal antibody analysis, and molecular detection of all viruses. Most hospitals don't do that. They send it to the public health lab to isolate, everything from poliovirus to adenovirus to hepatitis to just any number of different viruses that we deal with, RSV, influenza, on and on and on. But rabies and arboviruses were big enough and problematic enough that there was a separate unit at the Department of Health, and a position opened up to create molecular diagnostic tools for rabies and arboviruses like dengue and West Nile viruses and things like that. And that's where, my career was born, really. When I jumped at that position in 1994, I started down a path of working with zoonotic agents. So the job, and we don't have to talk too much about this right now, but it was an interesting job to start my career because 50% of the job was lab work, actually working in the lab and just doing the regular day-to-day rabies and arbovirus testing. But the other part, because we were in the middle of a rabies outbreak in Texas, where we had two epizootics that were raging in South Texas and West Central Texas in coyotes and fox, that it was a public health emergency declared by the governor at that time in 1994. And so I was allowed to develop, by working through CDC and other expertise, bring in the first big molecular testing and sequencing for Texas. I helped create the regional rabies reference laboratory that would type variants from all over the country and Mexico and Canada. So it's funny to me looking back, Luis, because I was doing things with variants and molecular typing almost 25 years ago, and it's been all the rage because of the current pandemic in the last 2 years, but it's something that's been around for quite a while. I was also part of the team that helped eradicate canine rabies from Texas by using aerial delivery of recombinant rabies vaccination for wildlife. So just an amazing program. We can maybe talk about that sometime. But with respect to monkeypox, we had a group of veterinarians, wildlife biologists, epidemiologists, laboratorians like me, and we had something called a rapid response team, an RRT, and our job was to investigate outbreaks of a zoonotic background, especially if there was mortality, so if someone died. And so early on, we were doing lots of rabies and hantavirus. You might remember hantavirus blew up in that time frame, coming out of the Four Corners area of the U.S. But we also did plague work and West Nile work. I was there when West Nile burned across the United States, including Texas, monkeypox, avian influenza, anthrax. So just really cut my teeth on some really amazing times, and getting mentored by some amazing virologists at CDC as well as globally, and within Texas. So yeah, so I was cutting my teeth on some of these things 25, 30 years ago, and eventually got back into academia and now share that with my students as a possible career path.
Wow, definitely. Yeah, it's very interesting.
We'll have to do it. We'll have to do a show sometime on rabies alone. It's one of my passions for sure.
Yes, I will definitely ask you to come in again, and because definitely there's so many questions that I have, and also I want to delve a little more in your public health background, your transition to the clinical lab, and yeah, so we'll make some very good episodes.
Absolutely.
So for the audience out there, just hang in there. We'll have Dr. Rohde back on the podcast.
Sounds great.
So if you do get the monkeypox, what are the treatment options?
Yeah, great question. So if you look at, some of this comes out of CDC. I was telling Luis, I was writing an article about this today, and really there's no great treatment options. There's supportive therapy, so we all know what that means. You're treating the symptoms, not so much curing the illness. So there's not a lot treatment wise. There are some drugs. There's an antiviral that CDC talks about. There's the immune globulin treatment that we kind of talked about with COVID, but none of it has worked super well with rapidly curing the disease. It has been used in some instances to help control an outbreak. but most of the studies with the current drugs have been done in animal models, and they're still looking at in vivo human types of efficacy. However, in 2019, the U.S. Food and Drug Administration actually approved the first vaccine for monkeypox, which also protects you against smallpox. And again, you can find this if you search for it. It's the first non-replicating vaccine to prevent smallpox and monkeypox. And it's really for 18 years and older, and really only used for high-risk individuals. So again, like if you're working in this field in research, or you live in these countries and there's a reason for you to get them, then that would be something you might check out. I'm trying to think right now what the name of the vaccine is. Let me give that a little bit of thought while we're talking. It's relatively brand new, and I guess I've jumped around so many conversations today, it's skipping my brain right now, but there is an actual vaccine. I think it's pronounced Jynneos. Yeah, that's right. Jynneos. And it's made from vaccinia, which is closely related to variola or monkeypox. It's less harmful, but it can provide cross protection against both those diseases. So anyway, there is a vaccination that's out there now that allows us to really look at those who are probably high risk. They even talk about, for example, people with HIV in those African countries are a little more at higher risk because they're immunosuppressed, as you know. But even other immunocompromised individuals, might be a problem. And then anyone who works either in the research setting or maybe in the field, like they're working with rodents or, wildlife biologists and people like that might take that vaccine. That's probably if you didn't get it, didn't get the smallpox vaccine back in the 60s or 70s. I'm not sure. I have to do a little more digging, Luis. I'm not sure if they're recommending using that as like a booster or not. I would have to dig that up.
Is there anything else that you want to add about monkeypox?
I don't think so. I think we did a pretty good job. Kind of it's kind of the big picture view right now, which is nice to talk about. Certainly, I would, tell your audience and others not to panic. I don't think it's anything of grave concern. I think it's probably going to burn out. Everything in historical respect has shown us that. That doesn't mean, something could happen and this has a new novel transmission, but I don't see it being as problematic. And there was even some discussion from several experts how, ironically, because mask mandates were so mandated on travel up until recently, that probably was super helpful because, less ability to transmit it through aerosols or inhalation of respiratory droplets, because, everybody had to wear masks on aircraft and elsewhere in the last, year and a half. So that was probably a good thing. And so really, I think it's all going to be fine and good, and it'll probably burn itself out in the next, weeks to months, but we'll keep our eye on it. And it's just a good reminder again. I say this all the time. Public health and the medical laboratory are very integrated. They each have their place, and they're absolutely critical to healthcare. As you know, they're the foundation of public health and healthcare, those professionals. So just thank everybody out there that's doing that work. And I appreciate you for having me on the show, and I look forward to our next conversation.
Definitely. It was my pleasure, and not only to inform the audience and at the same time inform myself. Something really good that you said about, as of right now, like historically the cases seem to be small. So for people not to panic, because of course, since what we've been going through for the past 2 years, probably the easiest will be to hear about a virus and start panicking again. And that doesn't do any good to anyone.
Right. That doesn't help at all. And it's an important point because, many experts, including myself, are kind of talking about that even right now and also with like the acute hepatitis outbreak that's going on that you might have read about. We're so sensitized as a society right now that we're probably a little overreaction by the press and by everybody else. And we have to react. We have to, pay attention to these things. But, if it hadn't shown up in the US and Canada, we might not be as hyper vigilant like we are right now, but we'll keep an eye on it and see what happens, see if it plays out. But I think we'll probably see this one fade away in the next month or so, maybe 2 months. I hope anyway.
Sounds good. Well, Dr. Rohde, once again, thank you for taking the time to come into Let's Talk Micro. It was definitely very nice to, we've been talking, either to like social media or email. So it was definitely nice to have a conversation with you. And I definitely look forward to future episodes of having you on.
Yeah, thank you so much, Luis. Again, as I mentioned at the beginning, it's an honor and a privilege. I really appreciate what you're doing. And just one quick reminder as we close out for your audience, there are a couple of articles I'm working on about this smallpox pandemic. One will come out in The Conversation, and the other will be in an ASM blog. So keep your eyes out for my social media feeds and my other routes of dissemination, and you can check those out. There'll be more details and a little more fully explained than what we talked about today. So thanks again.
And is it you're on Twitter as Rodney Rohde?
Yeah, I'm on Twitter as Rodney Rohde. A lot of people mess up my last name, so it's Rodney Rohde, all one word, Rodney Rohde. Again, I'm at Texas State, so I have a program Twitter handle, TXState_CLS. And that's my primary kind of rapid dissemination tool, but I'm also on LinkedIn and Facebook, and I have a YouTube channel. So again, you can find some things if you do some quick Google searches.
Yes, for the audience, I agree, because all you have to do is just basically type your name and Texas, and it comes right at the top, and then it gives you your website, and then from there you can see your publications and all your work, and even on ASM has a section where it gives you like a mini biography. So definitely very easy and accessible for the audience that if you want to learn more about Dr. Rohde's publications and his work. Okay, well, thank you so much.
Thank you, Luis. Yeah, thank you. We'll talk soon.
And that, my dear audience, is the end of this episode, of the special edition episode. I hope you enjoyed it. I definitely enjoy learning more about monkeypox. It's always good to stay informed, but also, looking at the right sources. So, great conversation with Dr. Rohde. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.